Hi everyone, today I'm going to talk about neonatology. Let's start with birth weight. So small for gestational age is defined as less than 10th percentile, LGA over 90th percentile, low birth weight is under 2,500 grams, very low is under 1,500, extremely low is under 1,000, GBS screening should be 36 to 38 weeks, and then GBS prophylaxis is penicillin G. And then if you are GBS negative, but previously had a pregnancy where the infant had GBS disease, then future pregnancies, you should still get the prophylaxis. Okay, so fetal heart rate deceleration. So let's start with the mnemonic VO CHOP that many people use. So it goes variable, early, acceleration, and then late. And then CHOP refers to the etiology. So CHOP, variable refers to cord compression or prolapse. Early decels refer to head compression and they're a vagal response and are benign. Accelerations are okay. Late decelerations are due to fetal hypoxia or placental problems, like placental insufficiency, basically. So early decels are due to head compression. Variable decels are due to cord compression or cord prolapse. Late decels are due to placental insufficiency causing fetal hypoxia. Tachycardia is defined as heart rate over 160, bradycardia under 110. The best next step for late decels would be to measure fetal pH because that would give you a objective measure of fetal hypoxia. And if the pH is less than 7.2, then you should prepare to deliver them. Okay, and then in Canada, we use what's called the electronic fetal monitoring classification system. This is different from the American system, which has categories 1, 2, and 3, with 3 being the ominous category requiring delivery, whereas in Canada, we have normal, atypical, and abnormal classifications. And for each of these categories, we have like some recommended steps for management. So baseline, normal baseline is 110 to 160 beats a minute. And you can deviate from these as long as it's like a very short deviation. So atypical baseline would be 110, below 110 but above 100, so 100 to 110, and then you can be over 160 if the duration of tachycardia is less than 30 minutes, I believe. And then abnormal would be anything under 100, and then over 160 if it is for longer than, I'm going to actually say atypical would be 30 to 80 minutes here, and then abnormal would be over 80 minutes. So let's see how I did. Normal is 110 to 160, atypical is 100 to 110, or 160 for 30 to 80 minutes, and you might have a rising baseline or arrhythmia, so I missed these 2 points. Abnormal is less than 100 or greater than 160 for more than 80 minutes, and the erratic baseline, which I missed. Okay, so variability is another characteristic, and basically it means, let's say your baseline is like this, and then sometimes it goes up, sometimes it goes down, but normally we want a bit of variability. It should never like just be completely flat. So the normal amount of variability from baseline is 6 to 25 beats a minute. That's up or down. And again, you can have periods of high variability and periods of low variability as long as those durations are short, especially if a kid is sleeping, you might just stimulate them a little bit. We call that vibroacoustic stimulation. But in normal fetal heart monitoring, a period of minimum or absent variability is all right if it is less than 40 minutes in duration. And I'll just say a 0 for absent variability. Atypical variability would be absent variability or less than 5 for 40 to 80 minutes, similar to above, except it's 40 minutes instead of 30 minutes. And then abnormal baseline would be something greater than 25 minutes. I don't remember for the duration. I think it's like 30-minute duration. And then under 5 or absent variability for more than 80 minutes. And then the other pattern of variability that is concerning is sinusoidal variability. Let's see. Normal variability is moderate, 6 to 25. If it's minimal or absent, it's still normal if it's less than for 40 minutes, 40 to 80 minutes if atypical. And then for abnormal baseline, it's minimal or absent for more than 80 minutes, or marked, so that's greater than 25 for 10 minutes. So I got this one wrong. It should be 10 minutes, not 30 minutes. And the sinusoidal is the other pattern of abnormal variability. This is also a category 3 pattern in the American system, which requires delivery. Accelerations are not very important in this system. Usually we only care about accelerations in the NST setting. But for instance, if you stimulate the fetal head during a cervical exam, that's reassuring. So spontaneous accelerations are not required to classify the tracing as normal, but they are reassuring if you see them on scalp stimulation. And not seeing accelerations with scalp stimulation is concerning, but they don't change the classification. Okay, decels are quite complicated. So If you have no decels, that is normal. Non-repetitive, uncomplicated variable decelerations are normal, and early decelerations are also normal. Remember, early decels are due to head compression, which is a vagal response that is benign. Atypical would be repetitive uncomplicated or non-repetitive complicated, so complicated variable decels that just happen intermittently. And then intermittent late decels are also atypical, and if you have a single prolonged decel that is between 2 to 3 minutes, that is atypical. For abnormal tracing, it's repetitive complicated or recurrence late, or a single prolonged decel that is between 3 to 10 minutes. So I won't get into like what exactly complicated for versus uncomplicated looks like, but there are basically 3 features. So if the complicated variable decel lasts a long time, so it's prolonged, that is one feature. And then if it fails to return to baseline, that's another feature. And then if it completely overshoots, and I'll talk about what overshooting looks like afterwards. So obviously, if the baseline is normal, we're not going to really have to do anything, just continue monitoring. If it's atypical, we're going to pay a little more attention and then initiate intrauterine resuscitation. Intrauterine resuscitation usually involves stuff like repositioning the mother. Maybe you might give IV fluids. You might discontinue uterotonics like oxytocin if they are being given. You might add a tocolytic like indomethacin or nifedipine or terbutaline, depending on the gestational age. Things like that. You could consider fetal evaluations like scalp stimulation, as we mentioned. You can also do blood sampling, or ultrasound. So one type of ultrasound I've heard of is the measuring the blood velocity in the middle cerebral artery to assess for fetal anemia. That's more like usually in the exam setting. Usually it's like in the context of a parvovirus B19 infection or thalassemia or something like that. Abnormal, you're going to initiate intrauterine resuscitation as well as initiate delivery measures. Okay, so how does variable deceleration occur? So basically, you have cord compression, and this decreases venous return. So venous return goes down. As a result, there is a reflex tachycardia. And you can see this at the beginning of the variable decel as this slight tachycardic response. When the compression progresses, you have occlusion of the umbilical arteries, which increases the SVR. So the systemic vascular resistance goes up. And as a result, you get a bit of like a Cushing reflex. The Cushing reflex causes, as you guys know, a decrease in the heart rate due to an increase in parasympathetic tone. And so that is the cause of, well, that's thought to be the cause of the deceleration in heart rate. And then when the cord is decompressed, the sequence of events is going to reverse, and that's why you get a bit of a tachycardic response at the end. And this is what I mean by overshoot. So if the tachycardic response raises the fetal heart rate above baseline, that is considered an overshoot, and that is one of the concerning features that qualifies a variable deceleration as complicated. So once again, the 3 features of a complicated variable deceleration are 1, prolonged duration and amplitude. So long duration and large amplitude. Amplitude. The other would be an overshoot, and then the third thing would be not returning to baseline. So if you can imagine, the heart rate decelerates, recovers, but doesn't recover to baseline. So there's maybe like a gap between where it ends and the original baseline. And you should be familiar with like the criteria in terms of timing. So variable decels are V-shaped, so they have an abrupt onset, whereas early and late decelerations have a more gradual onset. And usually that's described as the time interval between the onset and the nadir, or lowest point of the deceleration. And usually 30 seconds is the threshold. So if it's less than 30 seconds between onset and nadir, that is abrupt, so it's a variable deceleration. If it's greater than 30 seconds, it is gradual, therefore it is an early or late deceleration. And early decelerations, intuitively, they begin before the contraction, and then late decelerations, they'll begin after the onset of the contraction, and they will end afterwards as well. Okay, let's talk about the differences between the Canadian system, the SOGC, and the American system, the NICHD system. So which system is more sensitive for detecting acidemia? That's going to be the SOGC, I think. But it's going to be less specific, I believe. Which system produces more indeterminate tracings? I believe that's the American system, NICHD, and that is because it puts more things in categories 2 and 3, and that's partly, let me correct myself. The US system is more sensitive because it categorizes more things as abnormal, but a lot of things get put into the category 2 classification. As a result, there's a lot of indeterminate tracings. So it's highly sensitive, but less specific. So answer to this should be the US system. Which system attaches explicit management actions to each? So that is our Canadian system. And then which system incorporates atypical deceleration descriptors? That's the Canadian system. I talked about these. So shoulders are those short periods of tachycardia before, after a variable decel. slow return to baseline, and minimal variability within the years, and also another descriptor. Which system applies the same schema to antenatal NSTs? I believe it's the Canadian system. Okay, so let's see how we did. So Canadian for antenatal NSTs, Canadian for the descriptors of variability cells. Explicit management is Canadian. And then, okay, the Canadian system is more sensitive, but it's less specific. That makes sense because the American system puts more things into category 2. Okay, that makes sense. Okay, vectoral association. This is a mnemonic. So V stands for vertebral, A for anal or anorectal. C is for cardiac, I believe. T is tracheoesophageal fistula. E is ear. No, E is, oh, actually, I think these are the same, I think. So they all mean TEF. R is for renal. L is for limb. Let's see how I did. Esophageal atresia. Okay, yeah, they were the same unit. And then to confirm the presence of a tracheoesophageal fistula, you insert a orogastric or nasogastric tube, and you find that it coils or stops at the esophagus, does not continue to the stomach on X-ray. Okay, torch infection pattern. So this is quite high yield, and it'll also come again when I do the infectious disease section. So if you have microphthalmia, cataracts, blueberry muffin rash, which is due to dermal hematopoiesis, as well as a patent ductus arteriosus, this is going to be rubella. Other features of rubella are sensory neural hearing loss and pulmonary stenosis, or pulmonary artery stenosis as well. Okay, so next one, microcephaly, periventricular calcifications. Okay, so that's like a buzzword for CMV infection as well as sensory neural hearing loss. It's also nice to know that CMV is the most common cause of non-congenital hearing loss. So like it's not, non-genetic hearing loss. So it's not caused by genetic mutations, but rather infection. Chorioretinitis, hydrocephalus, and intracranial calcifications. This is going to be toxoplasma. Snuffles, that's already a buzzword for syphilis. And then obviously syphilis can cause a lot of different things, but this is just a few of them. Fetal hydrops is a buzzword for parvovirus, B19. Okay, so rubella, CMV, toxoplasmosis, syphilis, and B19. Okay, teratogens. So cocaine it's basically something that causes vasoconstriction, and as a result, you'll have SGA, you'll have limb defects, you'll have intracranial hemorrhage or ICH, and placental insufficiency as well, because it's causing vasoconstriction. Cigarette smoking is also going to cause low birth weight or SGA. Lithium is classically associated with Epstein's anomaly, and this is a condition where the tricuspid valve is inferiorly displaced, causing what is described as atrialization of the right ventricle. ACE inhibitors relax the efferent arteriole in the kidneys, causing decreased GFR and decreased renal function, decreased GFR and decreased urine output, which leads to oligohydramnios and then Potter sequence. And the characteristics of Potter sequence would be things like lung hypoplasia, renal dysgenesis, limb compression or limb defects, and skull ossification defects. Because you can imagine that just due to the compression, all the bones, joints, things like that, they don't form properly. Okay, phenytoin is associated with fetal Hayden-Toyen syndrome. So Hayden-Toyen syndrome. And I just remember that because they both have the Toyen at the end, Toyen. The characteristics of fetal Hayden-Toyen syndrome, I think it causes like cardiac and limb defects. There's probably other things as well. Valproate and carbamazepine, these are going to be neural tube defects or NTDs. PKU is going to cause microcephaly, which is a small head, and I always remember musty odor. I don't know why. So musty odor. It also causes cardiac defects and I believe small for gestational age, so SGA. Opiates will cause a withdrawal syndrome. So you can imagine just like anybody with withdrawal syndrome, what do they look like? So they're irritable, they're sweating, things like that. Okay, so cocaine is the most common substance implicated in SGA, also causes limb defects, leukomalacia, and intracranial hemorrhage. Cigarette smoking is low birth weight, lithium, Epstein anomaly. ACE inhibitors will cause growth restriction, renal dysgenesis, oligohydramnios, ossification defects, also limb problems, limb compression. Phenytoin is Hayden-Toyen syndrome, neural tube defects with these seizure medications. PKU will cause SGA, microcephaly, hypopigmentation. That's something that I've seen before, and musty odor. And then neonatal abstinence syndrome, irritability, poor feeding, sweating. Okay, discharge checklist. So they have to pass the congenital heart defect screen. So this involves two things. The SpO2, I believe, has to be above 95%, and the post ductal SAT difference has to be less than 3%. For a mother who is positive for hepatitis B surface antigen, you have to give HBV and HBIG within 12 hours. And I also talked about that in the previous video. Uncomplicated term discharge, so you can keep them in the hospital for 1 to 2 days, and then they should see their family physician within 2 days, or it's becoming more common for families to follow up with midwives as well, or midwifery clinics. Cord care, so in the past, people used to put different things on the cord, like alcohol or silver nitrate, I believe. But nowadays we don't really do anything. We just keep it dry, and that's fine. Circumcision contraindication. So a lot of families actually ask about circumcision. The contraindications are if they have some sort of defect that would require the foreskin to repair. So like if they have hypospadias, for instance, hypospadias, which is where the opening to the urethral meatus is on the ventral side rather than the very tip, and so you might use some of the foreskin to repair. I don't actually know how that happens, but that is one of the contraindications. And then of course, if you have a coagulopathy, so you don't want them to bleed out, right? And then classically, it's taught that circumcision might prevent infections and like penile cancer, but I think there's some evidence to suggest that that is more so due to like hygiene, so differences in hygiene rather than circumcision in and of itself. Anyway, it's not standard here anymore, at least from what I've seen. So CCHD screening, they have to be above 95% in SATs, and the difference between pre and post ductal SATs is less than 3%. Hep B vaccine and HBIG within 12 hours if they have hepatitis B serologies, and then you can keep uncomplicated term babies for 24 to 48 hours. They should follow up within 2 days. Keep the cord dry. And then, oh yeah, for micropenis as well, you don't want to give circumcision because they might need that to repair. Okay, so some questions. The mother is currently GBS negative, had a previous infant with GBS disease. Prophylaxis is recommended. We mentioned that earlier. Most common cause of infant deaths in the USA would be like chromosomal or congenital things. The third trimester presents with hemolysis, elevated liver enzymes, low platelets. So that's just the mnemonic HELLP syndrome. And the treatment would be just delivery, I guess. Best course of action if fetal pH is under 7.2 would be delivery. Which group has the highest infant mortality rate in the USA would be African American. And then in Canada, it would be indigenous groups. There's specific indigenous groups, including like Inuits and people who live up in the north with poor access to healthcare and things like that. Clinical significance of a single umbilical artery is usually associated with, I think, malformations or other like congenital anomalies, like 20% or more have these anomalies. Definitive treatment for preeclampsia or HELLP syndrome is delivery. Now, one thing that I learned recently about preeclampsia is that the blood pressure can actually continue to increase after delivery, and it peaks at about 3 to 7 days postpartum. So that's why you want to just keep monitoring their blood pressure, make sure nothing happens. Okay, so GBS negative will still require, but they had previous GBS positive pregnancy, still requires prophylaxis. Most common cause of infant deaths, congenital malformations, HELLP syndrome, deliver if fetal hypoxia. African Americans have the highest mortality rate among infants in the USA. Single umbilical artery has association with fetal anomalies, and deliver to treat preeclampsia and HELLP. The NRP is the Neonatal Resuscitation Program. I'll talk about that later on. So the best course of action in cases of late deceleration is to measure the fetal pH. A newborn infant is apneic with a heart rate under 100. Best thing to do, I think, is just PPV, which is positive pressure ventilation. And you do this for 30 to 60 seconds. I think in the newest version of the NRP, they recommend 60 seconds before moving on to more advanced measures. Heart rate is under 60 beats a minute despite adequate PPV and the Mr. SOPA corrective measures. So Mr. SOPA is just stuff that it's like a mnemonic for what you can do to check that the PPV is working well. And so you've done all the steps and they're still very bradycardic. This is when you start thinking about CPR. And you can add 100% oxygen as well, so 100% O2 via the PPV. Newborn with lanugo on the shoulders, creases on the entire foot, scant vernix, both testicles in the inguinal canal with good rugae, approximate gestational age. So I have no idea what this is, but I know what they're referring to. This is referring to parameters on the Ballard scoring system for prematurity. And basically, it's like a very fancy physical exam that you can do for kids to determine their gestational age. But normally these days, we rarely do it. Like I asked a resident in year 4 if she's she's ever done it. She says she's only ever done it once in like 5 years. So the Ballard scoring system has mainly been replaced by just dating ultrasounds, and most people these days have access to that, at least in Canada. Newborn at 1 minute with a low heart rate of 90, weak, irregular respiration. They have a grimace, they have some flexion, and acrocyanosis. What's the APGAR? So APGAR is a mnemonic, so the appearance is the first thing, and basically referring to the acrocyanosis. So they have an appearance score of 1. P is pulse. This is going to be a score of 1 because it's less than 100 beats a minute. G is also going to be a score of 1 because G goes from nothing to grimace to cries and pulls away. And then A, the second A is activity. So this goes from no activity to flexion, and then just like lots of activity. So this is also going to be a score of 1. And then R is going to be respiration, and here they have weak irregular respiration, so that's also a score of 1, I think. Actually, wait a second. So the first A, which is appearance, should be a score of 0 because appearance goes from nothing to acrocyanosis to pink, and here they have blue body and limbs, which would be a score of 0, just like completely cyanotic. Okay, so this should be a score of 4. Infant's heart rate remains under 100 with no chest rise during PPV. What are the corrective steps? And so we just talked about this. This is Mr. SOPA. It stands for mask, reposition. What's the S? The S is suction. O is, I think it's open the airway or open the mouth. P is pressure, so add pressure, and then A is airway. So yeah, those are the things, sort of like the steps you can do to make sure that the PPV is working well. Lastly, infant's heart rate remains under 60 despite adequate PPV and chest compressions. What's the next step? So this is where you start thinking about epinephrine, Q 3 to 5 minutes, and you would need intravascular access for this, so either umbilical vein or IO or even IM if you had to. Okay, so let's see how we did. Late decels, measure the pH. Good. Apneic with a heart rate under 100, do PPV. As I mentioned, they've sort of increased the duration in the latest iteration of the NRP. So it used to be just 30 seconds and then you move on to the next step, but now I think it's 60 seconds. If it's under 60 beats and you've already done the PPV, you've already done the Mr. SOPA, that's when you start doing CPR and you add 100% oxygen. And this Ballard score thing, I don't think it's really that important to know, but I think the features are helpful. Like basically if a baby has lanugo, they might be a little older because that's like some of the older skin being shed. APGAR of 4, we got that. Mr. SOPA, mask adjustment, reposition the airway, suction the mouth and nose, open the mouth, increase pressure. That's referring to PPV, and then airway alternatives such as a laryngeal mask or something like that. Infant heart rate under 160 despite CPR and PPV, so that's when you start doing epinephrine. Okay, so this is a slide on the NRP, the latest version. So the first thing you do, of course, like the logistics, cord management. If they're looking good, then you initiate skin to skin and just maintain temperature, all that good stuff. The first thing you do is just try and stimulate them. So you warm them, you dry them, and you stimulate. So usually it actually looks quite dramatic. So the pediatrician or whoever, nurse, I don't know, maybe a med student will take the baby, put them in a cot or the machine thing, and just like violently rub them with a towel to stimulate them. If they are not breathing well, so apnea or gasping or have a low heart rate, you move on to the next step. If they don't, but they look cyanotic, you do something else. So if it's a respiration problem, you start ventilation. If it's a cardiac problem, you start their SpO2. But remember that most most cardiac looking things, quote unquote cardiac, are actually resp. So it's usually still just like oxygen and CPAP. If the heart rate still is below 100, then you do the Mr. SOPA steps, and you can consider like a laryngeal mask or cardiac monitoring or something like that. If the heart rate drops or is like really low, under 60, then you can initiate chest compressions, as we mentioned, 100% oxygen. And the very last step, if it's refractory to CPR and 100% oxygen, is epinephrine. Okay, and then here are some like different SpO2 targets for different ages as they age. Okay, and this is Mr. SOPA, as we talked about before. This is the Ballard scoring system. There's basically two components to it. There's the neuromuscular part, and then there is the physical part. I have a mnemonic for it. PEP war for the neuromuscular, please beg for the physical. But again, I don't think it's very high yield. It just kind of be like familiar with the things that you might look for. So like palmar crease might be absent, lanugo will increase, things like that. Okay, so neonatal skin findings and scalp stuff. A newborn with one side of the body pink and another side pale. So this is something called harlequin color change. This is basically like a vasomotor response. It's benign. Newborn with a sharply demarcated ulcerated area of absent skin. This is congenital aplasia. Congenital aplasia cutis. It's associated with some syndromes in terms of medications, it can be caused by maternal methimazole use, which is often used for Graves' disease or hyperthyroidism. Newborn with head swelling that crosses the suture lines after vacuum-assisted delivery. This would be caput succedaneum, and this is caused by, I can't remember, I think, is it the it's not the bridging veins, it's something else. Anyway, the next one is head swelling that does not cross the suture line, so it is limited. This would be cephalohematoma. Next question, neonate born with severely thickened skin with large, shiny hyperkeratotic scales, deep fissures, contraction abnormalities of the eyes, so they have severe ectropion. Okay, so this is harlequin ichthyosis. It's a very striking appearance. What is the most common association with aplasia cutis congenita? So actually, if they're born with aplasia cutis, it's usually isolated. They don't have any other syndromic features or any other problems. A newborn with progressive head swelling after vacuum delivery, the swelling is ill-defined with crepitus and fluid waves extending into the neck. So it's not limited by sutures and it's growing larger and larger and larger. This is subgaleal hemorrhage. Okay, so first one was harlequin color change. We got that. Absent skin is aplasia cutis congenita. If the head swelling crosses suture lines, but it's not progressively expanding, like the last question is succedaneum. If it is not crossing suture lines, it's cephalohematoma. Harlequin ichthyosis is the thing with hyperkeratotic scales, deep fissures, and the contraction abnormalities. So basically, you can imagine that if you don't have like that pliability to the skin, the structures become like sort of really tight and taut, and so that's what's causing some of these contraction abnormalities. Aplasia cutis is usually isolated, and then progressive head swelling with the extension into the neck is subgaleal hemorrhage. Okay, so the image on the left is this very striking appearance of harlequin ichthyosis. The picture in the middle is harlequin color change, and you can see that there's a very striking difference in color from the right and left side of this child. And then this area here on the skin is ulcerated. This is aplasia cutis congenita. On the left, we see a swelling that, head swelling that's really on the back of the head. This is common for caput succedaneum. It's limited to the suture lines. And then cephalohematoma is, you can see it's sort of like outlining these suture lines. Okay, or caput succedaneum is crossing the suture lines, right? Because it's above the periosteum. One of the complications could be jaundice, because you can imagine like all the blood building up in this swelling will eventually get broken down, because it tends to resolve within 2 to 3 days is what we tell people. 24, 72 hours, I don't know. 2 to 3 days, or yeah, this should be 48 to 72 hours. So it tends to resolve in 48 to 72 hours. It does cross the suture lines. As you can see, it doesn't have like those sharp demarcations that you see on the right. And they might have jaundice just because of the breakdown of a large amount of blood within the swelling. You distinguish it from subgaleal hemorrhage because it, wait a second. Distinguish it from subgaleal hemorrhage because it will not have the fluid wave, and it's also not life-threatening. Okay, management. Caput succedaneum is benign, just wait for 2 to 3 days. 7-day-old, 28-week premature infant should be screened for which type? Oh, so this is not ICH. It's a type of intracranial hemorrhage called intraventricular hemorrhage, and you just do a ultrasound of the head for that. And you should repeat this, I believe, to see if they have post-hemorrhagic hydrocephalus. Okay, next, maternal fever of 100.4 Fahrenheit. I think that's like 39 Celsius. Fetal heart rate, so you have a bit of tachycardia, maternal tachycardia, purulent, foul-smelling amniotic fluid with leukocytosis and uterine tenderness. Okay, so if this is postpartum, I would say that this is chorioamnionitis. The other thing that I often get this confused with is endometritis. But I think endometritis is postpartum, chorioamnionitis is intrapartum, right? Because this is a fetal heart rate, not a neonatal heart rate. So this is a chorioamnionitis. Management of cephalohematoma, again, just like, I believe it's just reassurance. It will spontaneously resolve just like caput. Subgaleal hemorrhage, I'm pretty sure it's just like careful monitoring, and I guess refer to neurosurgery. I'm not sure. 2-day-old term infant born at home presents with blood oozing from the umbilical cord. So this is classic for a vitamin K deficiency. So the treatment you give is IM vitamin K. Neonate born after 35 weeks to a mother with chorioamnionitis is alert, good tone, no respiratory distress, normal vital signs. As long as there's no problems, I think we just observe 48 hours, which would be standard anyway, and then discharge if nothing serious happens. Okay, so let's check. Caput succedaneum, reassure. spontaneous resolves in 2 to 3 days. Intraventricular hemorrhage for premature infants, you do an ultrasound, check for that. Chorioamnionitis was the maternal fever and tachycardia, fetal tachycardia, and like signs of infection. Cephalohematoma also resolves spontaneously, but a little longer. I forgot to mention that. Subgaleal hemorrhage, you need to just carefully monitor things. And then do serial hemoglobin levels, of course, because you have progressive hemorrhage and the blood can break down, cause jaundice, and potentially like kernicterus or something if the bilirubin levels go up. The blood oozing from the umbilical cord, you treat that with iron vitamin K because a lot of kids at home, they're not getting vitamin K. And then the neonates born to a mother with chorioamnionitis, but otherwise normal, you can just treat them like a normal kid. So after 48 hours, you can discharge after, of course, serial monitoring. Chorioamnionitis and sepsis. So asymptomatic infant, 35 weeks with the risk factors. The current recommendation, if they're totally fine, then again, it's just monitor for 48 hours and then discharge. 2-hour-old term newborn with prenatal history of polyhydramnios has choking while breastfeeding, gagging on oral secretions. I believe this is going to be a tracheoesophageal fistula. Most common anatomic subtype of TEF, that would be the tracheoesophageal fistula. I think it's the H type. I think that's what they call it. I'm not sure what proportion, maybe like 1/3. And basically what that is like, let's say this is your trachea, and then here is your esophagus. The esophagus ends blindly, and then below there is like a fistula where the esophagus continues. So that almost looks like an H. A term infant 1 hour after birth develops tachypnea, hypoxia, and grunting. Chest radiograph shows fluid in the fissures, a flattened diaphragm, and prominent pulmonary vasculature. This would be TTN because transient tachypnea of the newborn involves a incomplete expulsion of pulmonary fluid, and the flattened diaphragm reflects like a hyperinflated lung. And the prominent pulmonary vasculature would also support the increased amount of fluid in the lungs. Preterm neonate under 34 weeks with risk factors. What is the best next step? Let's see. So sepsis, maternal fever. Okay, so if they have sepsis, obviously we're going to treat them different. The sepsis workup usually involves things like CBC, blood culture, urine culture, LP culture, like maybe an LP as well. And you might start them on IV antibiotics. Usually it's like ampicillin and gentamicin. Infant develops cyanosis when feeding, which disappears in crying. This is a classic description of bilateral choanal atresia. This is where the air, so kids are obligate mouth breathers. So basically the choana are blocked. So they have to open their mouths, kids are bilateral. Yeah, kids are obligate mouth breathers. They don't learn to breathe through their noses until after adulthood. But in choanal atresia, the oral airway, the choana are closed. And so when they cry, they increase the size of the oral airway, increasing the inflow of air, which improves the cyanosis. Okay. Long term, what GI complication is most likely after successful TEF and atresia repair? I think it would be GERD. Let's see how I do here. So 35 weeks with risk factors, you just observe. Gagging on oral secretions, that was TEF. And then the most common, it's type C, not the H. I don't remember what the H was then. Fluid in the fissures with the flattened diaphragm, that was TTN. Preterm neonate under 34 weeks with risk factors, CBC and blood culture, not the urine and LP. Bilateral choanal atresia is cyanosis that improves with crying. Again, because like that oral pharyngeal airway, or not oral pharyngeal, but that choanal airway is blocked. And then GERD from esophageal dysmotility after TEF repair. Yeah. Okay, CDH, PPHN, and pneumothorax. What are the risk factors for poor neurodevelopmental outcomes in congenital diaphragmatic hernia? So one risk factor is a right-sided CDH with the liver in the diaphragm area. Another would be pretty intuitive, but like if they had really bad ventilation requiring ECMO, or they had really high O2 requirements, that's also another risk factor. Term infant with respiratory distress on CPAP, CXR showing cystic lesions in the left lower lobe and a normally placed stomach. What is the diagnosis? So a normally placed stomach tells me that this is probably not CDH or diaphragmatic hernia. And then cystic lesions in the lung spaces is classic for congenital pulmonary airway malformation, or CPAM. Infant with cyanosis and preductal O2 sats that are less than the postductal O2 sats. So there are a couple of diagnoses that could cause this. Remember that the patent ductus arteriosus connects the descending aorta with the pulmonary artery. So usually it is actually the opposite. Preductal SpO2 is greater than postductal SpO2. In this case, you have what's called reversed differential cyanosis. One thing that could cause this is supracardiac TAPVR, which is where the pulmonary veins drain above the heart at the level of, I believe, the superior vena cava. The other cause would be TGA plus PDA with either coarctation or pulmonary hypertension, like persistent pulmonary hypertension of the newborn. A common complication from excessive bagging during resuscitation, so if you increase the lung pressures a lot, you can cause barotrauma and the alveoli collapse, and so you get a pneumothorax. What is the next best step in the newborn with diaphragmatic hernia? So the first thing is you want to intubate them because the intestines were going to be blocking the breathing. And then the other thing is NG tube, so you can decompress the stomach because a lot of air is probably in the stomach, and regardless whether there's a lot of air or not, you can decrease the amount of air and allow the lungs to inflate. Full-term infant with tachypnea, cyanosis only in the lower body, loud second heart sound, preductal over postductal SATs, clear lungs, and decreased vascular markings on CXR. Okay, so usually when I think of cyanosis only in the lower body, I'm thinking of like a coarctation, but here they have a loud second heart sound, which to me implies pulmonary hypertension or another cause of high pulmonary vascular resistance, such as pulmonary stenosis. And then their preductal SATs is greater than the postductal SATs. This is consistent with pulmonary hypertension. And then they also have decreased vascular markings. I'm guessing this is decreased lung vascular markings, and they also have clear lungs. I'm going to say PPHN for this one. Post-term newborn with respiratory distress, meconium stained amniotic fluid, and displaced maximal cardiac impulse. So the diagnosis, I think, is going to be, again, pneumothorax. And the same mechanism, basically meconium blocks the airways, and then you have this ball valve effect, I believe, and some of the alveoli collapse, atelectasis, and then you get pneumothorax. So let's see how we do. Right-sided hernia, ECMO, and then you have to repair it, I guess. I forgot that one. And then supplemental oxygen. CPAM for the other one, and then the 3 diagnoses for reverse differential cyanosis, where TGA with PDA and either PPHN or coarctation, or supracardiac TAPV-R or TAPV-C. TAPV-C is just total anomalous pulmonary venous connection, which is like basically the same thing as TAPV-R. Excessive bagging, if you have a bag valve mask, that can cause pneumothorax. If they have a diaphragmatic hernia, you want to intubate and then decompress. Tachypnea, cyanosis in the lower body, blah, blah, blah. This was PPHN, and then meconium with the displaced impulse was pneumothorax. Okay, so on the left here, we have a picture of congenital diaphragmatic hernia. So you can see that there is a hole on the left side of the diaphragm, allowing the guts to move up into the lung spaces. And so that's what all this stuff is on the left side, and the lungs are displaced to the right. On the right side, we have a picture of CPAM, or congenital pulmonary airway malformation. And basically it's like these cyst-like spaces. They might be filled with fluid, or they might be filled with air. I'm not quite sure. And you can see that here. So instead, these are like the cysts. They're kind of like round, and they have air or fluid or something in them. And they also push the lungs and heart onto sort of the left side, and the diaphragms, on the other hand, in contrast to diaphragmatic hernia, look intact. So they look similar in terms of like the lung fields. They have these like the round spots, and they're pushing the lungs one way or the other. But the diaphragm is intact in CPAM and compromised in diaphragmatic hernia. Okay, so here is a picture of a heart with, I believe this is trying to show supracardiac pulmonary venous return. So the pulmonary venous return carries oxygenated blood, which mixes with the deoxygenated blood in the superior venous cava, and as a result, you have oxygenated blood entering the pulmonary artery, so that through the ductus, you will increase the oxygen saturation of blood compared to the blood in the more superior or proximal portions of the aortic arch. Yep. And one of the reasons for that would be because the pulmonary veins are draining not into the left atrium as they normally do, but rather the superior venous cava. Okay, so here on the right is reverse differential cyanosis due to TGA, coarctation, and PDA. So first, TGA means that the aorta is coming from the right ventricle and the pulmonary artery is coming from the left ventricle. And as a result, you have oxygenated blood leaving the left ventricle and returning to the left atrium. So you have these like two parallel circuits. But in the context of a coarctation, what happens is that the pressure in the descending segment of the aorta is relatively low because not a lot of blood can pass across the coarctation. As a result, more blood leaves the pulmonary artery into the descending aorta through the PDA, resulting in an increase in distal SpO2 in the aorta compared to the proximal aorta. So these are two mechanisms of reverse differential cyanosis. Okay, meconium ileus and Hirschsprung's and NEC, or necrotizing enterocolitis. So first of all, meconium-stained amniotic fluid is noted at delivery and the infant is apneic. First step would be PPV. Previously, we used to intubate or suction, but now we're going to just start with PPV. To confirm Hirschsprung's, so there's two things that you could do. The first thing that you can do is rectal suction biopsy, but the confirmatory study is apparently a full thickness biopsy, which you can imagine is just a little bit more complete and comprehensive. Newborn with bilious vomiting, abdominal distension, and lethargy, you have to rule out midgut malrotation with midgut volvulus. Meconium ileus in a newborn should prompt workup for cystic fibrosis due to the, I can never pronounce this word, but inspissated secretions or something. Like the secretions become really, really thick, and then you just develop meconium. Failure to pass meconium in the first 24 to 48 hours of life is concerning for Hirschsprung's. A 2-week-old preterm infant with increased gastric residuals, abdominal distension, blood in the stool, abdominal wall erythema, a kidney, ureter, bladder scan shows pneumatosis intestinalis and gas in the portal vein. So this is NEC. Pneumatosis intestinalis is sort of the buzzword here. Investigation for bilious vomiting. So you want to do x-rays and an upper GI contrast study. So let's see. PPV for the meconium stained amniotic fluid, rectal suction biopsy for Hirschsprung's, and the findings would be no ganglion cells, and you have acetylcholine esterase positive hypertrophic nerve fibers. Absence of ganglion cells is pretty classic. It's because there's like a problem in the migration of these neurocrest derivatives. Volvulus malrotation has to be ruled out if you see a newborn with bilious vomiting or lethargy. Meconium ileus is associated with cystic fibrosis. Hirschsprung's causes a failure to pass meconium in the first 1 to 2 days. Necrotizing enterocolitis if you see pneumatosis intestinalis, and upper GI contrast series for an infant with bilious vomiting will allow you to determine the location of the ligament of Treitz, and that will help you determine whether there is malrotation or not. Okay, duodenal atresia and neonatal eye nerve stuff. So newborn with Down syndrome and bilious vomiting, KOB shows double bubble. This is duodenal atresia. It's a classic buzzword. Anhidrosis, ptosis, meiosis, and ophthalmos. This is Horner syndrome. It's a damage to the sympathetic pathway. So stuff like the stellate ganglion and all that. Newborn is not moving arm and hand. Hand is held in a claw-like position. So this is Klumpke palsy or Klumpke palsy. This is damage to the C8, T1 nerves, the lower trunk of the brachial plexus, including the ulnar nerve, resulting in a damage to the lumbricals. And the lumbricals usually extend the metacarpal phalangeals and flex the, the lumbricals normally flex the MCP joints and extend the IP and distal phalangeal, oh my god. The lumbricals are damaged here, so they can't function normally. The lumbricals are not damaged, the lumbricals are impaired here. Lumbricals normally flex the MCPs, extend the IPs, and extend the DIPs. So what happens in Klumpke palsy, so this is what lumbricals normally do. If you think of this as your wrist, and then these are your fingertips, what happens in Klumpke palsy is the MCPs are the hinge there. The MCPs cannot be flexed, so they're extended. And then your IP joints and DIP joints are flexed, so you have like a claw, or question mark in this case. Okay, 2-month-old with irritability, port feeding, swelling, bone lesions, elevated ESR ALP. There is layered periosteal new bone formation with cortical thickening of long bones, mandible, and clavicle. This is what's called CAFI disease, or infantile cortical hyperostosis. It's benign, I believe, and the buzzword would be layered periosteal new bone formation with cortical thickening, and sometimes you do get these inflammatory markers. Differential diagnosis for white pupillary reflex. So there's cataracts, but the most important thing to rule out would be retinoblastoma. There's also, I think, retinopathy of prematurity if they are premature. There might also be some association with congenital infections, including torch infections. Newborn is not moving the arm. The arm is adducted and internally rotated in waiter's tip position. So that is like this position. So if their head is here, their arm is sort of like that behind them. I don't know. Anyway, so this is Erb's palsy. This is different from Klumpke palsy in that Erb palsy affects the C5, C6 nerve roots, or rather the upper trunk of the brachial plexus. But diagnostic tests should be performed to assess associated findings in brachial plexus palsies. So you should actually do an X-ray because there might be clavicular fracture. Okay. So let's see. Double bubble sign was associated with duodenal atresia, anhidrosis, ptosis, meiosis, think of Horner syndrome. Claw-like position, think of Klumpke paralysis or Klumpke palsy. The layered periosteal new bone formation with elevated ESR ALP, that's CAFI disease or infantile cortical hyperostosis. White pupillary reflex, think of cataracts, retinoblastoma, retinopathy of prematurity, and torch infection, as well as this thing called Coates disease, which I don't remember. Erb's palsy is waiter's tip, and then if you see brachial plexus palsies, do a CXR to rule out clavicular fracture. And also also for phrenic nerve injury, which I forgot about. You can do an ultrasound of the diaphragm for that. And this is a picture of what that absent red reflex or white pupillary reflex looks like. Okay, so I think this is trying to show CAFI disease or infantile cortical hyperostosis. So one of the things that you can notice here is there's a bit of inflammation or periostitis of the lower ribs on the right side here. So you can compare that to the ribs on this side. I think they just look a bit thickened. There's a bit of inflammation there. And then the other thing I'm noticing, I think this is a femur. There's like this thickened line, bright line. So this is consistent with like cortical new bone formation. And then I think this last image on the bottom right is just trying to show hyperostosis and like periosteal new bone formation in the clavicles, which would be classic for CAFI disease. Okay, benign neonatal findings, neonatal hypoglycemia. 5-day-old female with vaginal bleeding. This usually is due to estrogen withdrawal because the mom has a bunch of estrogen, a bunch of hormones going on. You withdraw the estrogen, progesterone, and so on, and then you get a bit of bleeding. So this is benign. Neonate has new onset seizure activity, otherwise healthy. You should refer to specialist or ED because neonatal seizures are never normal. LGA, lethargy, tremors, seizures, cyanosis in a neonate. I think this is hypoglycemia, and you can check glucose levels for that. 4-day-old LGA, persistent hypoglycemia, and slightly enlarged tongue. I'm pretty sure this is Beckwith-Wiedemann syndrome. There's a mnemonic that's popular. It's hot boil. Hot boil. I don't remember all the components of it. But if it comes up again, I'll try and remember it. So well-appearing term neonate with bluish discoloration of the hands and feet. So this is just acrocyanosis. I think this is totally fine. Peripheral cyanosis is usually not a concern. It's pretty common. Small repetitive jerking movements that only occur during sleep and disappear when awake. This is benign sleep myoclonus. This is also benign. It's in the name, benign and common. Hypoglycemia that is diagnosed with 30 mg per deciliter level. So you're going to, you're going to get a plasma level to confirm. And then the second thing you'll do is initiate like repletion of the glucose. You can give them oral glucose if they are tolerating PO, or you can give them like dextrose IV or something like that if they can't. Okay, so we got all these. Let's move on. Neonatal jaundice, polycythemia, kernicterus, and newborn with micropenis less than 2.5 cm when stretched. I believe this requires endocrinology evaluation, like if they have congenital adrenal hypoplasia, maybe a 21 hydroxylase deficiency or 17 hydroxylase deficiency or something like that. Jaundice, hypocalcemia, hypoglycemia in a neonate. This is going to be due to polycythemia. The breakdown of RBCs causes a jaundice and hypocalcemia, and then the high amount of RBCs also consumes a lot of glucose because RBCs require, they don't have the ability to use like other nutrients, right? Just glycolysis. 3-day-old infant of diabetic mother with hypoglycemia develops hematuria and a left abdominal mass. This is going to be renal vein thrombosis because they have a procoagulative state. There are different reasons for this, but essentially that's what you want to think about. 5-day-old, 36-week GA infant with poor feeding, lethargy, shrill cry, jaundice, increased tone. Poor feeding, lethargy, shrill cry. This is Kernicterus, actually. This is Kernicterus. Kernicterus has actually 2 phases. So the first phase is what's described here, and then the second phase would be like things like coma, opisthotonus, things like that. But the first phase is this. Poor feeding, lethargy, and so on. Okay, newborn is very quiet, cries very little, and prolonged jaundice and umbilical hernia. So the umbilical hernia is pointing me towards hypothyroidism, and that's also consistent with just the low level of energy and activity. So hypothyroidism for me. Treatment of polycythemia, so you can just give them fluids. If that doesn't work, you can transfuse, like volume exchange transfusion. Jaundice in the first 24 hours is always pathologic. So you're thinking of like rhesus incompatibility, other causes like other mismatches like HELLP or Duffy antigen incompatibility. Mild anemia would be due to ABO incompatibility. Okay, and then here I'm just showing the tool that we tend to use here in BC to calculate bilirubin stuff. It's called hyperbilly. There's other tools out there, but I think this is pretty good to know for your pediatric rotations and stuff. So you can just put in all your detail, takes in however many measurements you have, and it plots a graph of the expected TSB level, which is total saturated bilirubin, and you can add phototherapy or not. So it's very useful. Okay, kernicterus management and abdominal wall defect. So kernicterus, you're going to manage that with volume transfusion. You're going to do double the volume transfusion. Abdominal wall defect with uncovered abdominal contents. This is going to be gastroschisis or gastroschisis. I'm not sure how to say it. And it's on the right of the umbilicus. You have gastroschisis and exposed bowel. The first step is to cover it in like a warm, wet wrap to prevent it from drying out. And then eventually you will need surgical repair. Syndrome characterized by absent abdominal wall muscle and cryptorchidism. This is prune belly syndrome, And that is actually, it's sort of like a sequence actually. So prune belly syndrome is caused by a urine outflow tract obstruction causing megacystis or dilation of the bladder. And when the bladder gets really large, it basically prevents anything like developing properly. So if this is the person's head and this is their feet and this is, the bladder, the abdominal wall muscles don't grow properly. And also the descent of testes doesn't happen properly. So that's why you get undescended testes and no abdominal wall muscles. A condition specific to the infant of a diabetic mother. I learned this, still don't know why this happens. A small left colon. I learned this recently. Abdominal wall defect covered with a membrane associated with genetic syndrome. This is omphalocele. Infant with gastroschisis should be positioned in the right lateral decubitus so that the bowel, if they're on the right side here, their bowel falls to the right, and that way it doesn't twist and potentially cause like volvulus or something. Okay. Terragens, torch, SGA. So first of all, it's full-term newborn with missing right index, middle, and ring fingers. This is amniotic band syndrome. A very small infant with a mother who used multiple drugs during pregnancy. Which substance is responsible for SGA? We mentioned this already. The most common would be cocaine. Newborn with microphthalmia, cataracts, blueberry muffin spots, hepatosplenomegaly, and PDA. This is rubella. We also talked about this. Newborn with jitteriness, irritability, tremulousness, limb defect, leukomalacia, and intracranial hemorrhage. Okay, so the first thing I'm thinking of here is hypocalcemia, but there's so many different things going on. I think this is going to be an infection. I'm leaning towards CMV infection. The most common effect of cigarette smoking during pregnancy, we mentioned this already, it's going to be SGA. Virus that can cause fetal high drops, parvo B19. Newborn with microcephaly and periventricular calcifications. I think this is CMV. Now I have CMV twice. I'm not sure if that's right. Let's see. So a full-term newborn with missing, so the first one was amniotic band, cocaine, SGA, rubella with blueberry muffin, hepatosplenomegaly, and PDA. Okay, so this one was actually cocaine abuse, and I do remember now that cocaine is associated with leukomalacia and intracranial hemorrhage. Okay. And then low birth weight, not SGA for cigarette smoking, and then fetal high drops for parvovirus B19, and the CMV infection for periventricular calcification. Okay, and that concludes this section.